As Hilda was saying, I'm Corian Grey and I'm a public health doctor, so I'm coming from a slightly different perspective. I'm coming from a population health perspective, and I've been asked to talk about cardiovascular disease. So these are some of the things I'm going to cover in the next half hour or so. I'll give a little bit of context and talk about Pacific peoples in New Zealand. I'm sure a lot of you will know this already. I'll then talk about the life expectancy gap and recent trends in cardiovascular disease, and then talk about some of the factors that could be contributing to the trends that we see. I'll talk about some possible strategies to address the equity gap, and then I'd really like to get your thoughts and ideas about cardiovascular priorities for Pacific peoples, because I know there's a lot of expertise in this room and I really want to capture it while I'm here. So before I get into all of that, I guess I'd like to share with you why Pacific health is so important to me. This is a picture of my family, so my mum, my dad, my brother and my sister. I was born in Samoa. My mum's Samoan and my dad's New Zealand European, and we moved to New Zealand when I was 5. And the primary reason we moved here was because my brother has a few disabilities and chronic health conditions, including what is still very treatment-resistant epilepsy. And so we moved to New Zealand in order to access better quality care for my brother, including some surgeries and some physical therapy. And so from an early age, I was really kind of hyper-aware of how life-changing being able to access good quality care is. And so the primary reason I went into medicine was to help not only my family, but families like mine access good quality healthcare. And I'd also like to, I guess before I start, acknowledge Pacific perspectives, Dr. Debbie Ryan and Brendan Mistrewski. Recently we published this paper called Tofa Saili, a review of evidence about Pacific health equity, and that was designed to feed into the health and disability system review that Heather Simpson is currently undergoing, and so a lot of the stuff that you see in this talk is from this. And I'd encourage you guys, if you are interested in more detail about Pacific health equity, that this publication is available on the Health and Disability System Review's website under the appendices. So, I mean, we've got lots of Pacific people in the room and people who work with Pacific people. We all know that Pacific is not an ethnic group. You know, people talk about being Samoan or Tongan. It's really just an umbrella term to describe a population of people made up of a number of distinct ethnic groups, languages and cultures. So as Hilda was saying, the 5 largest groups in New Zealand are Samoans, who make up about half of Pacific peoples in New Zealand, followed by Cook Island Māori and Tongan, who each make up about 20% of people, and then Niuean and Fijian. But despite this being an umbrella term, there are some commonly shared values amongst Pacific peoples that have been well articulated by the Ministry of Pacific Peoples. And these include the central place of family, collectivism and communitarianism, so everyone working together towards a common good, the importance of spirituality, attributing life events to a higher power, reciprocity, that mutual help and interdependence, and respect, particularly for our elders and for people in positions of authority. So we've just got the results, just some high-level results from the 2018 census. And there are about 382,000 Pacific peoples living in New Zealand. So they make up about 8% of the New Zealand population. And that's up from a little less than 300,000 at the 2013 census. We haven't got the kind of a lot of detail from the 2018 census, so a lot of the results that I'll be talking about today are still from the 2013 census. We're a very young and youthful population, so a third of Pacific peoples are aged under 15, compared to 18% of non-Pacific people, and only 5% are aged over 65. And we're also very diverse, so 1 in 4 Pacific peoples are like me, they identify with more than one ethnic group. And that diversity is increasing, so 40% of Pacific children aged under 5 identify with more than one ethnic group. And despite this kind of perception of Pacific peoples being a migrant population, In fact, the majority, about 60%, are now born in New Zealand. And even among those who haven't been born in New Zealand, 60% have spent more than 10 years in New Zealand. So one of the really important things when we're thinking about planning for health services are looking at where Pacific peoples are based. And like Asian people in New Zealand, we're very much an urbanised population. And this table here shows the number of Pacific people as at the 2013 census in the seven DHBs with the largest Pacific populations. So about 85% of Pacific peoples reside in these 7 DHBs. So in counties Manukau and Auckland DHBs, we've got quite a high percentage of Pacific people, so more than 1 in 5 people living in counties identify as Pacific, and more than 1 in 10 people living in Auckland identify as Pacific. Also, 2/3 of New Zealand's Pacific population resides in the 3 Auckland DHBs. So Auckland is a really important place when we're thinking about Pacific people. But even within DHBs, we find that Pacific peoples are concentrated in specific localities. So this table here shows 4 localities in counties Manukau, the number of Pacific people, the share of the total New Zealand population, and the percent of that locality that is Pacific. So as you can see in Mangere Otara, 6 in 10, 60% of the population living in that locality is actually Pacific. And 20% of New Zealand's Pacific population resides in that locality. And then in Manukau, there's 1 in 4 people living in that locality is Pacific. And so that's really important to know because when we're thinking about targeting of health services and where people are concentrated, that's really useful. We also know that Pacific peoples face some challenging socioeconomic circumstances. So this table here shows how Pacific people compare with the total population when we're looking at specific socioeconomic factors. So compared to the total population, Pacific people have higher rates of unemployment, are far less likely to live in areas of high deprivation, lower weekly earnings, much lower rates of home ownership, and we know that they're declining as well, and higher rates of overcrowding. Despite that, we also know that Pacific peoples report high levels of well-being and social connectedness, and this is really important when we're thinking about the strengths within our communities. So this data here in this table is from the New Zealand General Social Survey, which looks at well-being. So as you can see, compared to New Zealand Europeans, Pacific people are just as likely to rate their overall life satisfaction as high and their life is worthwhile and feeling safe in their own neighbourhood. But also, compared to New Zealand Europeans, Pacific people are more likely to report face-to-face contact with friends or family in the last week. So there's that social connectedness. And consequently, they're less likely to report feeling lonely. So just moving on to some of the health outcomes, I'm sure many of you have seen this graph before. This graph shows trends in life expectancy over the last 15 years. And public health people love life expectancy because it's a really good summary measure of how well a population is doing, because it's basically the average length of life a person born today is expected to live based on current mortality trends. So as you can see here, this is the trends in life expectancy for non-Māori and non-Pacific. This is for Pacific and this is for Māori people. So as you can see, over that time, there's remained this gap in life expectancy of about 6 or 7 years. But the other thing to note, and I was just talking to Wing about this in the morning tea break, is that trends in life expectancy have been fairly flat for Pacific people. So if you look at Māori, they've been increasing, which is great news, and it looks like the gap for Māori is actually reducing, but we don't see that reduction in the gap for Pacific peoples. So earlier this year, there was a paper published in the New Zealand Medical Journal, which actually looked at the specific conditions which were contributing to the life expectancy gap for Māori and Pacific peoples. And these two graphs show the conditions contributing to the life expectancy gap for Pacific men and Pacific women. So for Pacific men, the top three conditions were coronary heart disease, diabetes, and lung cancer. And for Pacific women, it was diabetes, coronary disease, and stroke. So this table shows a similar sort of thing, but grouping all the cardiovascular diseases together. So this table shows the years contributing to the life expectancy gap for these specific conditions. So as you can see, cardiovascular disease contributes almost 2 years to the life expectancy gap for Pacific men and over a year for Pacific women. Diabetes is also a big one, and we kind of sort of think of cardiovascular disease and diabetes together. So together, these conditions contribute about 2.5 years to the life expectancy gap for Pacific men and 2 years to the gap for women. And cancer is also a big one. But today I'll concentrate on cardiovascular disease. So the next few graphs is from some research that we did at the University of Auckland, which were looking at trends in coronary disease deaths and hospitalisations between 2006 and 2015. So on the left we've got coronary disease deaths for men, and on the right we've got women. So red shows the trends for Māori, Pacific are in blue, Indian are in green, Europeans in black, and then Asian, non-Indian Asians in purple. So as you can see from this graph, there remains this huge gap with Māori and Pacific men and women having much higher rates of cardiovascular disease deaths. And then we also calculated the average rate of decline over this time. So for most groups, the average rate of decline was between 4 and 5% per year. For Pacific men, it was a little bit lower, about 3%, but for Pacific women, it was much lower, about 1% per year. So we've looked at the deaths, so this shows deaths on the right, and we also looked at trends in coronary disease hospitalisations. And this is what we found on the left. So despite Māori and Pacific people having the highest rate of coronary disease deaths, we found that it was actually Indian men that had the highest rates of hospitalisations. And we were quite surprised at this. So to look at this a bit further, we calculated a ratio of hospitalisations to deaths. And this equated to about how many men are hospitalised with coronary disease for every man that dies. So for Indian and Asian men, the ratio was about 7 or 8. So about 7 or 8 men are hospitalised with coronary disease for every man that dies. For European men, that ratio is a bit lower, it's about 5. But for Māori and Pacific men, that ratio was much lower, about 3 or 4. And then we find a similar thing for women. So that the ratio of deaths is about 8 for Indian and Asian women, about 6 for Europeans, and again quite low, under 4 for Māori and Pacific women. So we're not really sure what this means. Obviously there's a whole bunch of factors that could be contributing to this, but clearly there's something to do with access to care, that Māori and Pacific people are just not able to access care for coronary disease. This is I've just kind of added this graph. We've got a student at the moment who's looking at trends in stroke over the same time period. So this is kind of hot off the press, she hasn't published this yet. And this is stroke incidents, so people without a history of stroke who either die from stroke or are hospitalised with it. And this is in the young people, under 65s. So as you can see, here we've got European, Indian and Asian rate, and then again you've got this equity gap. So then we ask ourselves, what are the factors that could be contributing to this equity gap? And we all know all about the socioeconomic determinants of health and how important they are. But I'd also like to focus on the risk factors and comorbidities and access to and quality of care. So Bryan did a great talk just before morning tea about diabetes, so I don't need to go over this in great detail. But there's this huge equity gap in diabetes for Pacific people. And by the time a Pacific person is age 65, over 60% of the population has diagnosed diabetes. So that's something we need to get our heads around. And Bryan also talked about multimorbidity. So that's the presence of 2 or more chronic conditions in a single patient. And that's associated with poor physical functioning, mental health, quality of life. And there's a growing body of evidence around multimorbidity. But also our health system is at the moment very much based on a single disease equity. You come in and someone will treat you for pneumonia or cellulitis. It's also associated with polypharmacy. So there have been a few studies in New Zealand looking at multimorbidity, and there's increasing interest. And estimates vary, but no matter what study you look at, Pacific peoples have the highest rates of multimorbidity. So a group down in Otago looked at multimorbidity using hospitalisations and pharmaceutical dispensing, and they estimated that about 14% of Pacific adults and 8% of Europeans had multimorbidity. And there was a recent study in a Dunedin general practice which found that almost 2/3 of Pacific people had multimorbidity and over half of Māori. So this graph is from the study from the University of Otago. I just took this off the internet. And this basically shows the prevalence of multimorbidity based on hospital discharge diagnoses. So as you can see, and this is the age group along the x-axis. So as you can see, at each age group, Māori and Pacific people have far higher rates of multimorbidity compared to other groups. I didn't show, they also had prevalence of multimorbidity based on pharmaceutical dispensing, but I'm not sure I think that information is useful because again we've got that access gap. So Pacific people might be less likely to access pharmaceuticals. So there's lots of evidence that shows that Pacific people have high rates of unmet need for healthcare. On the right here we've got a graph of ASH rates for 0 to 4-year-olds. And whether you believe in ASH or not, ambulatory sensitive hospitalisations are all about hospitalisations that could potentially have been avoided with good quality primary care and looking at the social determinants. So for years and years, so this is 2006 to 2016, Pacific children have had ASH rates that are twice as high as the total New Zealand population. And when we use the comparison group, the total New Zealand population, it actually includes Pacific people. So the gap is actually larger than that. We also know that the New Zealand Health Survey every year includes a few questions on unmet need for care. So I think the questions are, in the past 12 months, were you unable to access primary care for whatever reason? So we know that Pacific people have about the same rates of access to GP care as the total population, but they report higher rates of unmet need for care and higher rates due to cost. But I'm particularly interested in this one. So 18% of Pacific people reported that they had not filled a prescription in the last 12 months because of cost, compared to 7% of the total population. So I recently completed my PhD. It took me a very long time, 8 years. But it's not a race. It's not a race. On cardiovascular disease and access to care. And here are some of the things that I found. So compared to Europeans, Pacific and Māori people are 50% more likely to die from coronary disease before reaching the hospital. They're 50% more, so once they reach the hospital, they're 50% more likely to die from coronary disease in the 28 days following hospitalisation. They're less likely to travel to hospital by ambulance when they're having a heart attack. And they're less likely to receive coronary revascularisation, so that's either stenting or bypass surgery. And they're also less likely to be maintained on long-term medications after a heart attack. So we specifically looked at lipid-lowering therapy, but the same is true for other medications. And yes, these differences do remain significant even after we adjust for demographics and other factors such as comorbidities, hospital of admission, and prior disease. And adjusting for hospital of admission is really important because Pacific peoples tend to be concentrated in urban areas. We don't have rurality as a factor, so we can't say that Pacific peoples aren't able to access care because they're in the rural areas. Actually, they're in the they're in the areas where they've got tertiary hospital facilities. So now we ask ourselves, what can we do to achieve equity in cardiovascular disease? And we don't have the answers, but here are just some of my thoughts. So obviously, socioeconomic determinants are really important for Pacific people. So we really need to think about reducing socioeconomic inequities and mitigating against the effects of poverty. We also need to address cardiovascular risk factors in the obesogenic environment, and that includes looking at diabetes and doing some of the great stuff that Bryan's doing. We need to improve access and quality of care right along the cardiovascular pathway, address the health literacy needs of our services and communities, increase the Pacific health workforce, including pathways into leadership, encourage regular monitoring and robust evaluation of services and programs by ethnicity, and we need to have strategies that are led by and take advantages of the strengths of our Pacific communities. So when we think about access and quality of care, we have to remember that access is a pathway, right from preventive and primary care right through to secondary care. So in primary care, people get risk assessed. They have their cardiovascular disease risk assessed, and then they can get some advice on lifestyle changes and also medications, which have been shown to significantly reduce their risk of having a heart attack. So that's the lifestyle advice and the pills. Optimise and control of comorbidities, including diabetes. And letting people know about the symptoms of a heart attack and what to do, because what's really important when you are having a heart attack is access to defibrillation, and that means ringing an ambulance. And for those of you who live in the Wellington region, congratulations, you have a free ambulance, but for the rest of the country, it's $80 if someone calls an ambulance for you. Making sure that we have equitable access to interventions which have been shown to reduce your risk of another event after you've had a heart attack. Making sure that people have access to medications after their heart attack, and cardiac rehabilitation, which there's lots of evidence around cardiac rehabilitation, but the rates of completion are really low. So health literacy. People love to talk about health literacy, but we have to remember that health literacy is actually about the health system. Having a health system that makes sure that people are able to understand information and take things away so that they're able to action that. So there's a lovely nurse down in Wellington, Dr. Tuasua, who completed her PhD looking at Samoan people's knowledge and experiences of cardiovascular disease and risk assessment. And it was amazing what she found. People said to her, oh, my doctor came in and told me that I need to come in and have a heart check, but they didn't put me on a treadmill, they didn't do an ECG, they just took my blood pressure. So people didn't understand what the cardiovascular check was all about. and then they weren't able to action any lifestyle advice because they didn't find it relevant to them. So, we have health targets in place that talk about completion of risk assessments, but actually that's meaningless if it doesn't translate into change for our people. The Ministry of Health also developed a really good framework for health literacy, which is all about the health system reducing health literacy demands on people and building the health literacy capacity of the workforce. And there have been numerous studies that have looked at language and communication in primary care. And even if people have really good English language ability, people again and again say, I'd really like to have the information in my own language because some of that medical terminology is really hard to understand. And also people do say things like the medical jargon is often used as a way for the doctors to kind of put themselves at a distance from me. So encouraging the use of interpreters and asking people, what do you understand from what I've just said? Do you understand what you have to do now? And because I'm a data person, we really need regular, up-to-date monitoring and robust evaluation. We need to track trends for our different ethnic groups. We need to assess whether interventions are actually making a difference. And for those that are, we need to scale them up. And we also need to ensure that inequities are improving and not getting worse. Let's keep an eye on that life expectancy gap and make sure that it's starting to improve. And finally, we need to make sure that everything we do takes a strengths-based approach because there are so many strengths within our Pacific communities. We have to take advantage of that high level of social connectedness, of the high levels of church involvement and of volunteering within our Pacific communities. And over here, I'm not sure if you guys were aware, but a couple of months ago, people from the Growing Up in New Zealand study published this study which looked at telomere length. Does anyone know what telomeres are? Yeah, so they're these little bits on chromosomes which people think is related to the length of your lifespan. So basically, the longer your telomere length, the longer your potential lifespan. And in the 4-year-old children, guess who had the longest telomeres? Yeah, it was Pacific kids. It was great. But so we've got the potential, but let's all get together and make sure that our kids are able to realise that potential. Earlier, a couple of months ago as well, the Heart Foundation and the Healthier Lives put together a grant for $2 million to specifically look at heart health inequities for Māori and Pacific people. And I've been lucky enough to be awarded that grant, so it's $2 million over 3 years. And I'm co-leading that with Associate Professor Martiri Harwood. And we're going to be looking at quantitative and qualitative analyses focused on access to care.